estoy muy feliz de ser parte de este encuentro científico. Me gustaría agradecer a Servier Perú por la invitación, pero desafortunadamente mi español no es lo suficientemente bueno para una conferencia, una charla. Por lo tanto, hablaré en inglés. La próxima vez, pero en Perú, quizás hable en español. Gracias. Well, thank you very much once again for this invitation to be part of the Curso Internacional Víctor Alzamora Castro on the enfermedad coronaria isquémica. And today we'll talk about how to diagnose and how to apply the new concepts on the chronic ischemic disease, chronic heart disease for patients with so-called in the past stable angina. So these are my conflicts of interest. Okay, it has been more than 200 years since Haberdin's first description of a new disease, which he called angina pectoris. So what has changed from first description of angina to the 21st century? Well, I would say that a lot has changed. If you take the 2019 European Society of Cardiology guidelines for the diagnosis of a stable angina, the first thing you will notice is that there's a change in the title of that paper. This is the 2019. If you compare it with the 2013 guidelines from the same European Society of Cardiology, you see that there's a new terminology, a change in the name of the disease. In the previous paper, we had stable coronary artery disease, and now we have chronic coronary syndromes. So there's a new concept here. We're moving from disease to syndrome. And why is that? And now the authors of the guidelines acknowledge that there is a dynamic nature of the coronary artery disease process. So we have different clinical presentations coming or ranging from acute coronary syndromes to chronic coronary syndromes. But more than that, we have different underlying physiopathological mechanisms responsible for ischemia. So different clinical presentations, different mechanisms for myocardial ischemia. So this is rather a syndrome rather than a single disease. And you can see here in the slide that if you have myocardial ischemia as the center of this disease, you may have a patient complaining of angina, having myocardial ischemia because of a fixed atherosclerotic narrowing, an epicardial stenosis. But you may have a different patient complaining of angina, again because of myocardial ischemia, but because that patient has microvascular angina. Or you may have a patient complaining of angina because of vasospastic angina. So again, different mechanisms for myocardial ischemia with maybe the same clinical presentation, stable angina. That's why you have to widen the concept from disease to syndrome. When you think about a patient, the common day patient, the patient you see every day, coming to you, and you consider the diagnosis of the stable angina pectoris, you think about that patient complaining of symptoms, and that patient will describe the symptoms as a pressure, a heaviness, a tightness, or a constriction in the center of the chest that is usually precipitated by exertion and relieved by rest. But you may have a patient complaining of angina that may happen usually or predominantly at rest. And that may occur from midnight to early morning. And that patient may not have effort-induced angina. So when you see a patient like this, you may consider it vasospastic angina. And finally, you may have a patient with recurrent episodes of chest pain that looks alike like classic angina pectoris. The pain may be precipitated by effort, but also may occur at rest, particularly if there is also a macrovascular spasm as a pathogenic mechanism. So you may have a microvascular angina happening at exercise or at rest. And remember that many patients may have more than one mechanism for myocardial ischemia. So this is rather a complex syndrome, not a single disease. But for so long, for so many years, we have been trained that if a patient complains of angina, that patient must have a stenosis. So it was just a matter of finding the stenosis and fixing the patient by getting rid of the stenosis, like for instance, putting a stent, placing a stent. So now the concept has changed a little bit. If you look back in 2013, 7 years ago, and this is a table from the guideline, and here you can see the pre-test probability of having obstructive coronary artery disease. And now we have the different probabilities based on the clinical presentation, typical angina, atypical angina, or non-anginal, the age and the gender, the sex of the patient, man or women. Let's focus ourselves here. For instance, in the patients with more than 70 years of age with typical angina, either a man or a woman. Best, if you have a man or a woman over the age of 70 years old complaining of typical angina, the thought pretest probability of having obstructive CED was something like 89%. Now look at the same numbers from the same table now in 2019, published in 2020. So now the numbers drop significantly. So now if you have the same man with typical angina over the age of 70 years old, now we don't have 89% probability of having obstructive CED, but 52%. So now when you compare those figures, those numbers for men and women over the age of 70, this is in the red bars, you see the 2013, in green, the 2019. So now you see that the pre-test probability of having obstructive CED is much lower than we thought. So how can we explain that those patients were still complaining of typical angina and not having obstructive CED? Because now we consider non-obstructive CED as a cause for myocardial ischemia. And this concept can be even more illustrated by this study, in which we look at the number of the percentage of patients complaining of angina after myocardial infarction, if the patient had obstructive or non-obstructive CED. Here you see in the red bars at the baseline and in the first year of follow-up, the percentage of patients complaining of angina having obstructive CED. Now look at the numbers or the percentage of patients with no obstructive CED here in this light pink color, those bars, and you see that those patients with no obstructive CED have at least the same, if not more, angina than those patients with obstructive CED. So now the challenge for the clinical cardiologist is a little bit greater than we thought in the past. It's not just a matter of finding the stenosis. A lot of patients will not have the stenosis and still complain of angina. And on the other hand, you may have a patient with stenosis without angina and without myocardial ischemia. So now we have to fully understand what is this disease called chronic coronary syndrome. Now let's, having this concept in mind, let's talk a little bit what is the optimal medical therapy. Very often when you read a paper, when you read a study, you see something like the patients enrolled in the study were on optimal medical therapy before being considered blah, blah, blah. So what is optimal medical therapy? Well, now we have a concept for that. If you look again, this is from the European guidelines, and this is very important because there are key issues, key statements in this definition of what is optimal treatment for a patient with chronic coronary syndrome. So what are those key issues, the key elements? Element number one, the treatment has to satisfactorily control symptoms. So you have to come up with a strategy, a medical strategy to control symptoms in a satisfactory way. Number two, you have to prevent cardiac events associated with chronic coronary syndromes. So you're talking about secondary prevention. Usually you have to have maximal, this is condition number three, maximal patient adherence. And number four, minimal adversity to control symptoms. You have to prevent events. The patient has to take the drug and the patient has to tolerate the treatment you are offering. And when the guidelines, when the authors of the guidelines come with the idea to recommend the first choice for medical therapy, pay attention to what they said. They recommended as first choice a combination or monotherapy of a beta blocker or a calcium channel blockers. And this has been a recommendation for centuries. But they, again, acknowledge, and this is very important, that there is no randomized clinical trial, control trial, that has compared this strategy, a beta blocker or calcium channel blocker, to issue prescription of any other anti-ischemic drugs, or even a combination of beta blocker and a calcium channel blocker. So they say, you know what? We still recommend as a first choice beta blocker or calcium channel blocker, but we don't have any data suggesting that this is the best strategy for symptom control or even tolerability. And when you put all together this combination and optimal medical therapy, we have plenty of a number of studies showing that this may be not optimal medical therapy for everyone. And I brought you here data from the ORBITA trial. You all remember the ORBITA trial, 200 patients with stable angina underwent the fake PCI or true PCI. So it's a double-blind randomized control trial of the role of PCI for symptom control and exercise tolerance. And you all remember that there is no difference whatsoever after 6 weeks of follow-up. But I'd like to draw your attention to the medical treatment and to the symptom control. This is pre-randomization, and you see here the functional class of angina ranging from 0 to 4, very limiting angina. And then let's see what happened at the follow-up in both arms of the trial, PCI and in the placebo. So here you have the numbers. So when you look at patients with class 3, class 4, after the PCI, the true PCI, or after a fake PCI, you see you still have something like 50%, almost 50% of those patients were still complaining of limiting angina class 3 or 4, and they underwent a PCI. But let's look at the treatment they were being offered to. Here's the treatment. So at this moment, at the follow-up, they were taking beta blockers, calcium channel blockers, or long-acting nitrates. So they had taken the triple hemodynamic therapy, they underwent a PCI, and half of those patients were still complaining of angina, limiting angina. So clearly, something is missing here. Something is missing here. And it's funny, to say the least, when you look at the guidelines and the proposal of the guidelines, now they avoided the first line, second line terminology. Now they came up with a stepwise approach. So first step, second step, still kept beta blockers or calcium channel blockers as the first step in patients with tachycardia, in patients with bradycardia, in patients with LV dysfunction. So for any clinical profile, there is a stepwise approach, a recommendation to better treat those patients. But you see, they didn't take into consideration if the patient has, for instance, vasospastic angina. You're not supposed to treat the patient with vasospastic angina with the beta blocker. You may make your patient get worse with the beta blocker. So if the patient has, for instance, low blood pressure, and if you consider vasodilators for those patients, blood pressure will get even lower, and this will be bad for the patient. So this is kind of funny proposal as a rule in the management of patients with chronic coronary syndrome. But this is being reviewed, and if you look into the text, but you have to read the text. If you read the text, you see that the authors say, you know what, this is the general concept, the general recommendation to treat a patient with chronic coronary syndrome, but they say this strategy must be adapted to each patient's characteristics and preferences, and does not necessarily follow the steps indicated in the figure. This is very important, because sometimes you are in a hurry, you are talking to your patient, to a physician, to a resident, and you just look at the figure and you see how they are recommending to treat your patient. But they say into the text, you know what, look into your patient. What is the hemodynamic profile? What are the comorbidities? And then come up with the strategy to treat the patient, and not necessarily follow this, this proposed strategy. So they are inviting us to look beyond beta blockers, beyond calcium channel blockers, and certainly beyond long-acting nitrates. And when they say something was missing, what it was missing was you have to target the cardiac cell. Because for the cardiac cell, it doesn't matter where ischemia is coming from. If it's coming from a fixed stenosis in the LAD, if it's coming from microvascular dysfunction or vasospasm, or a combination of the above, the cell is ischemic. And when the cell is ischemic, there are metabolic alterations during those periods of sustained ischemia. So the cell still relies for the ATP energy production on the free fat acid oxidation, which is less efficient compared to glucose oxidation. So you have to block that. And that's exactly what trimetazidine does. Trimetazidine blocks, at least partially, the free fat acid oxidation pathway, which again is less efficient than the glucose oxidation pathway. And when you block the free fat acid oxidation, you favor the glucose oxidation. So you will increase the production of ATP, you reverse the intracellular acidosis, you change the homeostasis of the cell. So now the cell, it works more efficiently. And the benefits of trimetazidine has been acknowledged for many years in different studies. This is a meta-analysis included in the guidelines, showing that trimetazidine has a consistent anti-ischemic, anti-anginal efficacy. And it's interesting, when you look now again in the 2019 guidelines, the indication of trimetazidine has been updated. I never understood why in the previous paper, trimetazidine was given a 2B class level of recommendation, and now, rightly I would say, they correctly put it a class 2A level of recommendation. But more than that, and again, this is a very important statement in this guideline, that we as physicians, in selected patients, and this is new, the combination of a beta blocker or a calcium channel blocker with trimetazidine may be considered as a first-line treatment according to the heart rate, blood pressure, and tolerance. So now we are allowed to combine trimetazidine right up front when you see a patient with stable angina with a beta blocker or a calcium channel blocker. You don't have to wait the patient to be considered refractory to consider adding trimetazidine. And why is that? Because we have so much data showing that if you add trimetazidine on patients on beta blocker, you'll increase the total exercise tolerance, and you'll increase the time to 1 millimeter ST depression. This is a marker of ischemia, stress-induced ischemia, exercise-induced ischemia. So you are protecting the cell from ischemia. So the patient now can exercise more. You're making the cell more tolerant to ischemia. This is a combination of a beta blocker and trimetazidine. This is very good. But many patients come to us on different background therapies for angina, a combination of beta blocker and calcium channel blocker or long-acting nitrates, or even the triple hemodynamic. So if we add trimetazidine to any combination of anti-angina drug, will get a benefit? Yes. Look at this data. Almost 1,000 patients with stable angina pectoris being treated with different therapeutic strategies, beta blockers in monotherapy, combination therapy, triple combination therapy. When you add trimetazidine, regardless of the background therapy, the patient will get better, and will get better and fast. See that in 2 weeks' time, in 2 weeks after you add trimetazidine, even if those patients are only obese, you'll get a significant decrease in the number of angina attacks per week. This is what we have to do, a fast and a significant relief of angina. And when you look at the exercise capacity in those patients, when you add trimetazidine, again, the patients who initially were unable to exercise, in 2 weeks' time, they are increasing their amount, the length of, they are able to exercise up to 6 months, for instance. So look at the figures. They are almost doubling the capacity, their exercise capacity in 6 months, from baseline to 6-month therapy time after you add trimetazidine. And there's another subset of patients who are very interesting to consider trimetazidine. Remember, if you are burning free fat acids, this is less efficient, you have less ATP. So maybe LV dysfunction is a clinical setting very interesting to consider for trimetazidine, because once you add trimetazidine and you improve the production of ATP, the contractility will go up. And we have data to show that. This is data published a couple of years ago in patients with angina and LV dysfunction, in whom, when you add trimetazidine compared to placebo, meaning optimal medical therapy without trimetazidine, you will increase by 23% the LV ejection fraction in those patients. And more than looking at the echo data, when you look at the survival rate of those patients, there is a significant difference favoring patients who receive trimetazidine along with optimal medical therapy compared to patients on optimal medical therapy alone. So a clinical benefit and an improvement in LV function. So remember, we have to consider this cell. But there's more. When you look at the heart rate of those patients, the outpatient patients being followed in ambulatory patients. So we have 44% of those patients in real world data, 44% of those patients have a heart rate higher, above 70 beats per minute. And remember, 75% of those patients were on beta blockers. But when you look at those who were actually 100% taking the beta blockers, you will still have 41% of those patients with a heart rate equal to or greater than 70 beats per minute. But it may get worse, because when now you look at patients with angina, they were taking beta blockers, they were having angina, and half of them, 50% of them, still have their heart rate above the recommendation to control the heart rate for better symptom control. So there's something again missing here, and we have a valuable tool to improve the heart rate control and go beyond. If you consider ivabradine for a better heart control, this is very important, but we may go beyond that. We understand now that ivabradine heart rate, we understand that compared to beta blockers, ivabradine increases more the diastolic time compared to the beta blockers. And by doing so, it will increase the time for myocardial perfusion in a greater extension compared to beta blockers. Number two, collateralization. Ivabradine, we have data showing that ivabradine promotes collateralization. And number three, ivabradine may preserve and increase the coronary flow reserve in patients with stable angina. So it's much more than a simple pure heart rate reduction. And when you consider a patient with increased high heart rate, what would be the optimal strategy for controlling the heart rate and offering a clinical benefit? There's data comparing up titration of beta blocker with a combination, early combination with ivabradine and beta blocker. And when you look at that data in these two different strategies, this gray line is the up titration of the beta blocker. And here you see the proportion of patients that were free of angina, who were free of angina. And dark gray or black line are the combination of a beta blocker and ivabradine. And you see that you offer a faster and more efficient control of the angina when you combine both agents, ivabradine and beta blockers. And again, when you look at the tolerability, remember the concept of optimal medical therapy, the tolerability, this combination not only is more efficient, but it's more tolerated, it's well tolerated compared to beta. So finally, I would like to share with you and my colleagues from Peru, what are the Brazilian guidelines with the chronic coronary syndromes? And we published this many years ago, actually. We published this in 2014. I was one of the members of the writing committee of the Brazilian guidelines. And at that time, it's interesting to note that we already gave trametazidine a two-way level of recommendation. What European guidelines did just the previous year, we did 6 years ago. Trametazidine, a two-way level of recommendation, and ivabradine as well. And the second point I'd like to make with our guidelines is that we put trametazidine and ivabradine before considering long-acting nitrates in the algorithm for symptom control. We published this 6 years ago, so pushing for an early use of a combination of trametazidine with the beta blockers, and in selected patients, a combination with ivabradine and beta blockers. So my final message, to stay on time, I'd like to thank again Xavier for this kind invitation. We are facing challenging times, difficult times because of the pandemics. I know the situation in Peru is not good, the same in Brazil. So we still have a lot of patients getting sick and even dying from this terrible disease called COVID-19. But the Peruvian Society of Cardiology, or la Sociedad Peruana de Cardiología, like the Brazilian Society of Cardiology, they are putting all the efforts to keep the medical education, to spread the scientific message, what is the new advancements in the knowledge of the science. So I'd like to congratulate the society and Xavier to be able to give me this opportunity to share this message. And I'd like to finish this with a humble honoring the guy, the man who started it all. This is William Haberdine, who first described so beautifully that new disease we just talked about, that angina pectoris, the way he called it. And he was humble enough, when he finished the description of the angina, he said that with respect to the treatment of this complaint, I have little or nothing to advance. And I bet that he'll be so proud to see in a session like this, more than 200 years after the description, how much we advanced in the treatment of this complaint. But remember, we have to consider the patient as a whole, the disease not as a disease, but as a syndrome. Not forget the cardiac cell as a therapeutic target. Trametazidine is that for you. And we have to consider the heart rate on that, and ivabradine is an option for that. So thank you so much for your attention, and I'll be more than happy to take any questions you may have after this session. Thank you so much. Muchas gracias.